Bismillahirrahmanirrahim. Our topic today is about the obstructive sleep apnea and a small hint on the adenoidectomy operation. My name is Dr. Muhammad Amir. I'm an assistant professor of otorhinolaryngology, Tanta University Department of Otorhinolaryngology. Starting with the general term, it's called the sleep disordered breathing. It includes the obstructive sleep apnea, which is the failure of the proper breathing during sleep due to the peripheral obstruction, or it might be due to the central sleep apnea. Central sleep apnea is the cessation of the ventilation during sleep due to the loss of the ventilatory drive. Here we're talking about the loss of the drive from the respiratory center itself in the brain. Pauses of respiratory movement for more than 10 seconds with no associated respiratory effort is termed central sleep apnea. Starting with the obstructive sleep apnea definition, it's excessive daytime sleepiness and daytime functional impairment. Apnea index, it's a very important term that denotes the number of apnea attacks per 1 hour of sleep. The presence of more than or equal to 5 apneic or hypopneic events per hour while sleeping with a continued respiratory effort in a symptomatic patient denotes the presence of obstructive sleep apneic patients. Very important questions that might be asked during the oral or the written exams is what's apnea, what's hypopnea, and what's the apnea-hypopnea index. The apnea is a cessation or near cessation of the flow more than 10 seconds at the level of the nostril, while the hypopnea is a continued breathing but ventilation decrease by equal to or more than 50% of the saturation and for 10 seconds as well, while the apnea-hypopnea index refers to the total number of apneas plus the hypopneas per hour of sleep. 3 grades of the obstructive sleep apnea might be encountered, starting with the mild degree where the apnea-hypopnea index, or we can call it in another word, the respiratory distress index, is 5 to 15, and the moderate degree where the index is ranging from 15 to 30, and the severe degree where the patient is suffering from an index more than 30. What are the possible causes of the obstructive sleep apnea? It's to be known that any space occupying a lesion in the respiratory tract from the nostril to the glottis causing obstruction of the respiratory tract might cause obstructive sleep apnea. So in the nose, it might be the deviated nasal septum, the hypertrophied inferior turbinate. On the nasopharynx might be the adenoid. It might be in the throat, the enlarged tonsils, or it might be a collapse in the pharyngeal wall. It might be congenital causes, inflammatory causes, neoplastic causes, or with the general conditions as the obesity. Some epidemiological facts in the obstructive sleep apnea. 1 in 5 adults has mild obstructive sleep apnea with apnea-hypopnea index more than 5. 1 in 15 adults has moderate to severe obstructive sleep apnea with apnea-hypopnea index more than 15. The predisposing factors include the male are more susceptible than the females, the body mass index more than 30, shortened the mandible and or the maxilla, the hypothyroidism, and the patient suffering acromegaly. As we can see in that diagram, it's the pathophysiology of the obstructive sleep apnea. Normally, the airway should be patent during the inspiration and expiration, allowing the proper oxygen to get into the respiratory tract. While for the patient suffering from the hypopnea, there is a partial collapse of the respiratory tract, while in the apnea, there is a complete collapse of the respiratory tract, causing cessation of the airflow. How to diagnose a case of obstructive sleep apnea. Starting with the sleep history, usually the patient or his roommate gave a complete detailed history about disturbed sleep pattern of the patient. Also, you can detect the predisposing factor or the patient with suffering obesity, jaw structures, the patient with the upper airway anatomy, or with the increased body mass index. Those patients are more susceptible to develop obstructive sleep apnea. You can diagnose the obstructive sleep apnea through the sleep questionnaire, And finally, the gold standard for the diagnosis of obstructive sleep apnea, it's the sleep study or the polysomnography. What's the polysomnography or the sleep study? In such a maneuver, the patient is set to sleep and different measurements are taken. The patient, while sleeping, you can measure the electroencephalogram, electrooculogram, the airflow through his respiratory tract is measured, the oxygen saturation during sleep is measured, the respiratory effort, the body position during sleep, and the derived information written properly in the report. It's the total sleep time, the sleep efficiency, the sleep stages, the number of arousals, number of apneas, number of hypopneas, and the snoring, also the oxygen position and oxygen desaturation during the time of sleep, and finally, most importantly, the different indices that can detect the level of obstructive sleep apnea. What's the treatment for cases of obstructive sleep apnea? After establishing the diagnosis, you can start in the mild cases with the conservative therapy, including the weight loss, avoid alcohol, other sedatives including the benzodiazepine. Also, the gold standard is the CPAP. It's an abbreviation standing for the continuous positive airway pressure through a mask applied to the nostril of the patient, a face mask, while giving the patient airway under pressure to compensate for the deficient oxygen given to the patient by his natural airway. Also, some patients get some benefit from the application of the oral appliances, and finally, it's the surgery to open the airway of the patient. So the CPAP would be the treatment of choice for those patients who are unfit for surgery, or for those patients with apnea-hypopnea index more than 15, suffering from the excessive daytime sleepiness, cognitive impairment, mood disorders, insomnias, and cardiovascular disorders. The main disadvantage for the CPAP is the compliance. It is very difficult to be compliant with that CPAP and apply that mask on your nostril before sleep every time. It's interfering with the traveling, interfering with the mobility from one place to another. For the adverse effects, it's the dry mouth, rhinitis, congestion, and it is treated symptomatically. What are the oral appliances? They are mandibular repositioning splints. It acts to help the mandible to protrude forward and hold the tongue more anteriorly away from the posterior pharyngeal wall, so it opens the airway. More effectively, it acts in the patient with the mild to moderate degrees of obstructive sleep apnea. So, when we choose surgery for the management of obstructive sleep apnea, in case of the failure of the conservative management, including the CPAP or the oral appliances, or if the patient refuses to wear the CPAP or finds himself non-compliant with that CPAP, what are the procedures that might help the patient of the obstructive sleep apnea? There are a variety of procedures that might help the patient of obstructive sleep apnea, and here we choose the procedure according to the place of collapse. So the patient suffering from collapse of the soft palate and the uvula, we find the surgery of the uveo-palatopharyngoplasty very helpful for them, with resection of the uvula and parts from the soft palate. For the patient suffering from tongue disorders, a group of the maxillomandibular osteotomy and advancement would be helpful for them. For those patients with multiple airway obstruction, we may resort to tracheostomy to open the airway of the patient. And here how the patient looks like before and after the uvulo-palatopharyngoplasty. What are the complications of obstructive sleep apnea? First, it's the hypertension, the heart failure, nocturnal ischemia and depression, and the traffic accident due to the daytime somnolence. Some students and colleagues asked for adenoidectomy operation hint, and here we start with the indications of adenoidectomy. It's marked enlargement of the adenoid up to it is interfering with the proper nasal breathing. So you have a child suffering from adenoid and it is markedly enlarged up to the level that it is interfering with the proper nasal breathing, making the child an oral breather. Or the adenoid is markedly enlarged up to the level that it causes complication like the oral breathing, like complication of the teeth, like complication of the repeated attacks of otitis media with effusion. Then the contraindication, when you are not allowed to do adenoidectomy, there is absolute contraindication like we said before in the tonsillectomy, where the cases suffering from hemorrhagic blood disease like the hemophilia and the purpura, and there is a relative contraindication when the patient is in an acute attack or during the epidemics, or there is a certain contraindication that might be corrected later on. And for the complication, refer back to the complication of the tonsillectomy. There are respiratory complication representing the most serious complication, the hemorrhage, which is the most common complication, including the primary hemorrhage, reactionary hemorrhage, and the secondary hemorrhage. Also, little complications to be encountered, like the injury of the teeth, a spread of infection to the airway, or the otitis media.